Ultrasonography is being used routinely for regional blocks. Today, I will show you how to visualize spine with ultrasound for sentinel neuraxial block. I believe that ultrasound spine is more useful to learn than the learning of peripheral nerve blocks because we do spinal anesthesia more frequently than we do the peripheral nerve blocks. Here the question arises, why do we need an ultrasound when we have been doing spinals blindly since decades? There are certain problems with conventional methods of spinal anesthesia. It is a blind approach. We rely mainly on anatomical landmarks. And in some patients, these landmarks are obscured in obesity, edema, variable anatomy, and scoliosis. We end up in multiple puncture attempts and difficult catheter placements. All these lead to trauma, paresthesia, hematoma. In epidurals, there can be accidental dural puncture, which can lead to post-dural puncture headache. Now let us see the advantages of ultrasound before puncture. We are able to identify midline of spine. We are able to identify the intervertebral level. We are able to see the proper insertion point in the middle of the back. And we are able to identify the angulation of needle insertion. It reduces procedure-related complications. It improves the quality of anesthesia and improves patient satisfaction. There is increased success rate on first attempt, so the number of attempts are reduced, and this improves technical and clinical outcomes. We are able to measure the depth of epidural space, which means we are able to measure the distance between skin and ligamentum flavum. This avoids accidental dural puncture. NICE guidelines 2008 recommends the routine use of ultrasound before epidural catheter. Spine should reflect like this, not extended like this. We use curved probe so that deeper structures can be visualized. For learning purposes, we place the probe in a vertical direction in the paraspinous areas. You will see a picture like this. So these are transverse processes, and this picture is usually called a trident sign. Next, we tilt the probe slightly towards the midline, and we see this wavy pattern. This wavy pattern is facet joints. Next, we turn the probe in a horizontal direction, and we see this dense black shadow. This is vertebral body, and this is spinous process. Now we move the probe up and down slightly, and we end up in this picture. This is dense dark shadow of spine, and these are two white lines. This is ligament flavum and dural complex. This is subarachnoid space, and this is anterior dura. We can measure the distance between. This is white line. It is about 4.5 centimeters. So we'll see that after 4 centimeter, we should be careful that we can end up in dural puncture. This is a more clear diagram. This is dura mater and ligament flavum, dural sac, and this is vertebral body. Next comes the marking. So the probe position where we were able to identify the structures, we keep the probe there and mark on the sides of the probe, midline and side. Now here we join all these lines and we find this center midpoint for needle insertion. So the take-home message is that we all should be familiar with sonoanatomy of spine. We should use it routinely for epidurals and difficult spine. We can practice scanning on volunteers and patients. We can practice on phantoms. We can attend workshops for hands-on training. And we can also attend online interactive scanning models. Thank you for your attention.